Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about a targeted approach to vitiligo treatment. Our moderator this evening is Dr. Brett King. He is Associate Professor of Dermatology at Yale School of Medicine in New Haven, Connecticut. Our speaker this evening is Dr. Brittany Craiglow, who's pediatric dermatologist, adjunct associate professor of dermatology, also at Yale School of Medicine in New Haven, Connecticut. We'd like to thank our supporter, Incyte Dermatology, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues, if you'd like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a survey link will be emailed to you. We'd greatly appreciate it if you could fill it in and send it back to us. Again, if you want to ask questions to our faculty, please submit your question using the question chat pane on the right-hand side of your screen. And I wrote a little note there so you can see exactly where you need to type it in. So without further ado, I will pass the floor virtually to Dr. King.
Hello, everybody. Welcome to this webinar. It is a great pleasure to be here. I apologize, I'm having a little bit of technical difficulties, but it is a pleasure to be here with Dr. Brittany Craiglow to hear a presentation on the use of ruxolitinib cream or Opzelura for treatment of vitiligo. Thank you very much. I think I've resolved my technical difficulties. The International Dermatology Education Foundation is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. This organization is run by Leon Kircik, for whom I am grateful for the opportunity to be here in his stead while he cannot be here tonight. These are previous educational sessions shown here. Again, the breadth of education and topics covered by these sessions is really broad, and I think brings really kind of very current topics to us in a easy to access format. Next slide. Again, Dr. Brittany Craiglow is a pediatric dermatologist and an adjunct professor of dermatology at the Yale School of Medicine. She, I suspect, has more experience using Opzelura and other medicines like it in the pediatric age group than probably any dermatologist in the world. And so we are grateful to have her with us tonight to talk about a targeted approach to vitiligo treatment. And with that, I'll turn it over to you, Dr. Craiglow.
Great. Thank you so much. Hi, everybody. Thank you for sharing your, Tuesday night with us. So we are going to talk about Opzelura tonight. I am gonna move a few things around here. I'm not used to this platform, but we're gonna do it. Here we go. So Opzelura is the first and only FDA-approved topical treatment for non-segmental vitiligo in both adults and pediatric patients. So it was mentioned that I am primarily a pediatric dermatologist. I do see some grown-ups, as I like to call them, in my practice, but I see a lot of kids, and as we know, vitiligo often presents in childhood, and so it is really nice to have a treatment option for our adult patients and our adolescents. So a little bit of housekeeping before we get going. I am obviously presenting on behalf of Incyte. No photos during the presentation, please. Everything that we'll talk about is consistent with the FDA guidelines, and we'll have to stick with on-label questions for this presentation. And we'll talk about safety, of course, and then the full prescribing information will be available at the end. All right, so this is the indication statement for Opzelura. It's approved for the treatment, the topical treatment of non-segmental vitiligo, and as I mentioned, in patients ages 12 and up. It's also approved for the short-term and non-continuous treatment of mild to moderate atopic dermatitis. We're not going to
I think we may have lost Dr. Craiglows.
Think she's back, but she's
Oh, we cannot hear you, Dr. Craiglow.
getting used to this.
Okay, great. Now we can hear you.
Oh, you couldn't hear me. Oh boy.
No, no.
Okay.
But now we can.
Now you can. Okay. Wow. We're getting all the kinks worked out here. Hopefully it's going to be just totally smooth sailing from here. Thank you everyone for bearing with us. So this is the important safety information. I think that in dermatology, we're getting more used to and more comfortable with this, with many JAK inhibitors that we have approved in derm, serious infections, higher rate of all-cause mortality. These have been observed in patients treated with Janus kinase inhibitors for inflammatory conditions, malignancies, and then MACE events, as well as thrombosis. So we'll go through this in more detail later in the presentation, and then really importantly, we'll look at the data in patients using Opzelura for vitiligo, because I think, you know, this is important to know, but I also think that context is useful, and we have data, you know, in our patients, which is, I think, you know, the most relevant, obviously, for us on a daily basis. Okay, so let's talk a little bit about vitiligo. It's a fairly common autoimmune disease. It's hard for patients. I think, you know, until Opzelura, there was no FDA-approved treatment for repigmentation, and it's obviously a very visible disease for most patients, and it can have really a huge impact on a patient's quality of life. And so, you know, one of the things I think when we see patients with autoimmune diseases, we get a lot of questions about, like, why did this happen, right? And I think, you know, the short answer is we don't know exactly, but we do know that patients with vitiligo and other, you know, similar inflammatory or autoimmune diseases, they have a genetic predisposition, right? They have this set of genes that predisposes them, and then there's this environmental component that, you know, kind of pushes them over the edge, and, you know, they ultimately have, you know, developed vitiligo. And I think the triggers are what patients get very fixated on. You know, there are many that have been discussed in the literature: sunburn, trauma, chemical exposures, maybe psychological stress. I think, you know, we never know in any individual patient. They're probably multifactorial. And so, you know, I think it's important to know this, but I think it's really important to help patients kind of move from the why and more towards, like, okay, what are we going to do about it? How are we going to treat it, right? It's important to acknowledge that sort of wanting to have a reason, but we don't have a great answer, at least right now. But if you do dermatology, you're going to see vitiligo. So, you know, up to 2.8 million adults in the US are living with vitiligo, and these patients are going to show up in our clinics. And, you know, interestingly, I think sometimes we'll be seeing a patient for a different reason, especially adult patients, right? Maybe they're there for a skin check, or, you know, they have a wart or something like this, and then we notice they have vitiligo. And many of those patients have been seen before for their vitiligo and been told there's nothing to do for them. So it might be a case where they're there, and we might be the one to say, hey, you know, there's actually an approved treatment now. And I think that's really validating for patients. It's very exciting, you know, to have an option. So the classification of vitiligo is based on these different phenotypes. Vitiligo is sort of this common umbrella term that we use for lots of different types of vitiligo. So we have non-segmental vitiligo, which can be divided into these subtypes that you see here: generalized, acrofacial, universal, or focal vitiligo. And, you know, it really is super heterogeneous, right? You know, you're never going to see two patients who look exactly the same. And I think that's one thing that, that's hard for us, but also hard for patients because it's really unpredictable, right? You look it up online and nothing really looks exactly like you do. But it has this very unpredictable course. You might have this focal area and that's it, or you might go on to develop really widespread disease. And I think, that kind of worry of worsening is really difficult for patients. So on the other side, we have segmental vitiligo, which is something that usually happens very quickly. It's usually distributes, on one side of the body in a segment. Usually they have early involvement of hair follicles. It progresses, like I said, fast, and then it usually stabilizes. So Opzelura is not approved for the treatment of segmental vitiligo. It's approved for non-segmental, and we're going to talk about that today. But just to kind of know sort of these categories, and non-segmental, it's this sort of bucket here, but everybody is going to look really different. And so I think, a few things about treating vitiligo that are super important are to understand that not all body sites are going to respond equally. Okay. And I think this is useful for, for us, it's really important for us to know, right? Because we have to be able to provide guidance to our patients. We have to let them know, where we're going to maybe to expect to see repigmentation sooner, other places that might not actually ever repigment, right? So I think, this is very useful, and you may have to say it over and over again to patients, because especially that first visit, there's a lot going on and they may not kind of hear you initially, but places that have higher density of hair follicles, so that's the face, arms, legs, belly, back, they tend to be places that repigment the fastest, okay? So the more hair follicles you have, the more chance you have for those melanocytes to track up, and we'll look at the different patterns of repigmentation, but those are the places that tend to come back faster. More slowly are places that have a lower density of hair follicles, okay? So tops of the hands, feet, and then areas that don't have hair follicles, or very few, so palm, soles, volar wrists, those places are probably not going to repigment, right? So this is a place where you're going to have, it's a hard conversation to have with patients, right? But you need to let them know that, you could put this cream on, your fingertips until the cows come home, but probably nothing is going to happen, right? Because we don't have that reservoir of melanocytes that we need in order to get the pigment back. And then the other thing is that patients who have areas of leukotrichia, meaning hair that has no pigment, those areas are also very unlikely to repigment, okay? So remembering that the hair follicle, sort of the reservoir of melanocytes, you see no pigment in the hair, probably not going to respond, or a lot less likely anyway. But on the flip side, oftentimes we see patches of vitiligo and we see lots of pigmented terminal hairs within there, see it commonly on the knees, and you can say to patients, hey, look at that, you have pigmented hairs in here. This is a place that probably has a pretty good chance of responding. And that's kind of useful to them, I think, to hear that, oh, well, it's sort of motivating to know that there's some clinical feature of their vitiligo that suggests it's probably worth, the effort of putting it in. Okay, so we're going to talk now about the mechanism of disease of vitiligo and then how Opzelura works. So vitiligo is, like we said, it's an inflammatory disease. We have this genetic predisposition plus these kind of triggering events that are really poorly understood. But basically, in the setting of these triggers, what happens is you get activation of immune cells, okay? So you see this, we're gonna go through in a stepwise fashion very nicely. So you get activation of immune cells, you have these CD8 positive T cells that come in, and then what do T cells like to do? They like to signal, right? They like to communicate. And so they come in and they start communicating. They start spewing out cytokines, and these cytokines, you can see here interferon gamma, really important in this communication pathway. What do? They kind of recruit their friends, right? So they come in, they call for backup, and then what happens is you get enough T cells, and then they start going after the melanocytes, okay? So they destroy the melanocytes, and then you get loss of pigmentation, okay? And so that's on the skin, what we see as the white patches, complete loss of pigment, right? And so when we think about treating vitiligo, we have to get rid of that immune system that's causing the problem, or that inflammation, right? Those T cells that are in there, if we don't get rid of them, they're going to keep causing the problem, right? They're going to keep perpetuating this positive feedback loop. So we need a treatment that's going to go in and eliminate those or reduce them enough so that we can get repigmentation. And then once you get rid of those immune cells, we need the melanocytes to repopulate the skin, okay? And so this takes time. This is not something that happens magically overnight. This is very different from lots of things that we're used to in dermatology, right? We have someone with atopic dermatitis, with psoriasis. We use a topical. If they're not better in a couple of weeks, we're moving on, right? That topical is not working. That is very different in vitiligo, and that is something that's super important to talk about at the beginning of treatment, because this is for sure a marathon and not a sprint. And it's hard. It's hard to kind of use a treatment every day when you don't have that reinforcement, especially at the beginning, that something's happening, right? But again, this is where you kind of set those expectations at the beginning, and then you're going to have patients be more adherent, and then you're going to have fun because you're going to see them, you know, getting their pigment back. And then once we achieve repigmentation, we want to keep it, right? And so that's sort of the third part of this, is that it's not necessarily over, right? Just when those, you know, when the pigment cells go back, because there are often resident memory T cells, right, that can get reactivated and lead to destruction of melanocytes again. So then you're back there at the beginning, okay? So first we want to get rid of the inflammation, then we want to repigment, but then we want to keep the inflammation away in order to have the best clinical response for our patients, okay? So Opzelura, or ruxolitinib cream, it is a JAK inhibitor. So JAKs we're kind of, you know, hearing a lot about them. They really have revolutionized dermatology in a lot of ways, JAK inhibitors have. So JAKs are proteins that you can see pictured here. They sit intracellularly. Basically, they kind of grab onto receptors, and they're message transmitters, okay? So what we have in, you know, any sort of inflammatory process, we have our cytokines, right? We have those messengers. They bind to their receptors on the surface of cells. That message gets transmitted intracellularly to JAKs. JAKs take that message, they pass it on to these things called STATs, which go down to the nucleus. They influence gene transcription. And then basically on the other end of this, you get more inflammation, okay? And so what JAK inhibitors do, what Opzelura is doing, it's binding to JAK1 and 2, these two enzymes, and it's interrupting the activation of STAT. So it's kind of, we'd like to think about it sort of like a relay race where a baton is being passed, but then you have something that's taking the baton and not passing it further, okay? So it's interferon gamma is signaling through this pathway, right? And JAK inhibition makes it so that those signals are not going through, or fewer of them are getting passed, and so you don't get that, you know, all those immune cells in and around trying to get rid of the pigment, okay? And so, so we have a treatment that can targeted, you know, a targeted sort of pathogenesis directed treatment that can go after this inflammation. And so once we get rid of the immune activation or decrease it, we have the repigmentation, right? And so this is what we mentioned before. This takes a long time, and there are different ways that this happens. And this is where photos are really, really, really important, okay? Because sometimes you'll have patients come in, and depending on how they're repigmenting, they might not actually realize that they're getting better, right? So there are these different patterns of repigmentation, and you can see them actually both concurrently, sort of in the same patch or in different areas in the same patient, but we can see perifollicular repigmentation. So this is really beautiful, actually, and this is where, you know, we have that reservoir of melanoblasts, and once you get rid of those immune cells, you can get that, you know, those pigment cells tracking back up the follicle, and then they start creeping out adjacent to it. And so what you see is these little dots around hair follicles of pigment, and then they kind of spread out, and then they eventually coalesce, you know, if a patient does well. And so this is where, again, you know, you see those pigmented hairs. You can be sort of like, you know, predict the future for that patient, and they're going to think you're really smart, because you're going to say, oh, you know, we might actually see little dots of pigment starting around these follicles in the next several months, right? So that's perifollicular repigmentation, but you can also have marginal repigmentation, and this is just like it says, it's coming in from the sides, okay? And so you can see actually in this photo, it looks like the patient might be having kind of both at the same time, and you've got that little circle there on the bottom, and so it's coming in, but it's also coming up to the follicle. And so this is, you know, if you have somebody who's doing this perifollicular repigmentation, you're going to see, you know, depending on when you see them back, you're probably going to see those little pigmented macules within the patch. But if it's happening marginally, sometimes that's harder to tell. And so this, again, is where photos are really important. In patients with more fair skin, sometimes you will need to use a Woods lamp to really get a sense, and then you can kind of practice, and you can actually take photos with a Woods lamp, so you can see how you're doing. So again, remembering to educate your patients about this is so important, because patients will come in, you know, they'll say, oh, I was given a cream, but it didn't work. And then you say, well, how long did you use it for? Oh, a few weeks. Well, of course it didn't work, right? It's way too early, okay? So kind of setting these expectations is really important because we want our patients to have the best outcomes possible, right? And so they need to know how to use it right, and they also need to have that motivation to keep going because, you know, again, it's hard to kind of do something every day when, especially in the beginning, you're not getting that positive reinforcement of it working, okay? All right, so now we're going to talk about efficacy and safety of Opzelura. So we'll look at the clinical trials that led to its approval and then some open label extension data that can sort of help us answer some more long-term questions, okay? And so, as I mentioned, this was you know, a study done in adults and adolescents. They had to have non-segmental vitiligo. They had to have at least 0.5% of their facial body surface area and then at least 3% of their non-facial body surface area. But their total body vitiligo couldn't exceed 10%. Patients were not allowed to do phototherapy, and then anybody who had complete leukotrichia, so white hair within any facial lesion, were excluded. Again, remember that white hair is a poor prognostic indicator, very, you know, a lot less likely that those patients are going to respond because they're missing that reservoir. It's too late. All right, and so what was done is, you know, a double-blind, placebo-controlled trial, which was 24 weeks. Again, you can tell right from the get-go, right? Repigmentation takes a long time. We're used to clinical trials and other things in dermatology, maybe 16 weeks for psoriasis or AD, right? We're looking at 24 weeks and then open label extension longer, and we'll see that, you know, where patients are at 24 weeks is not where they end up longer term. But so patients were randomized either to use Opzelura twice daily or vehicle. And then the open label extension, everybody was using Opzelura, and then there was follow-up after that. Okay, and so there were lots of endpoints here, but the primary endpoint, again, at week 24 was the proportion of patients who had a 75% improvement in their FAAD score. So that's a facial vitiligo area scoring index. And, you know, some of us are more familiar with this than others, but it's, you know, it's just basically a measure of how much vitiligo there is. Okay, so you could think of it sort of in a way similar to, you know, an EASI 75 or PASI 75, so 75% improvement from their baseline, okay? And then there were secondary endpoints looking at FASI 90 and then 50, and then looking at week 52 at these endpoints also. Okay, so this is what the patients looked like. You can see that they were, you know, quite well matched in the two parallel trials. Pretty good range of phenotypes. You can see the baseline scores. Duration of disease here, I think this is important. A lot of these patients had had vitiligo for a very long time. And importantly, while, you know, about 3/4 of them had stable disease, some of them did have progressive disease. So they were starting sort of while the ball was already rolling. And about 60% of patients had had prior therapy. And again, this was, you know, this was in a time where there were no FDA approved treatments, right? And many patients would go and see someone and they would be told there's nothing to do for you, right? Before that, you know, there were lots of things that were tried off label, but, you know, nothing sort of reliably effective. But you can see about 15 years since the initial diagnosis and then about 7% total body surface area affected. Okay, and so you may forget pretty much everything I say, hopefully not everything, but you will probably remember the pictures. And these are, you know, pretty dramatic and I think really, really fun to see here, but like super fun to see in real life when it's your patient and they're feeling, you know, many of them feeling really different because they're feeling more like themselves again. So this is a patient, again, so we're going to look at sort of progression over time. And this is a patient by 12 weeks actually had, you know, fairly good improvement compared to baseline. And then you can see she had an 80% improvement all at week 24, still had a little bit going on the forehead, but you can see here, you know, you can see that beautiful perifollicular repigmentation and, you know, a very nice result. So this is looking at the percent of patients who got to that FASI 75 at 24 weeks and then out to week 52. Okay, so again, remember, this is a marathon and not a sprint. And not surprisingly, you know, when you look at the slope of that curve, so you look at week 24, about 30% of patients are hitting that benchmark. And then you go out to week 52, keeps going up, right? So you get about half of patients who are getting a 75% improvement from their baseline. And then you can see that placebo rate quite low, right? 10%. And then of course these patients get flipped over to active drug. And then you can see those numbers match up pretty nicely, 28 and 30%. So you can see that this is, you know, this is real, right? Okay, and here's another picture of a patient. So this is, again, this is really illustrating that this is something where you really have to stick with it. I think, you know, what's nice is that this patient, while he wasn't completely there at week 24, he had evidence of improvement, right? He had that perifollicular repigmentation. This is somebody who you're kind of going to be their cheerleader. Like, they need somebody to say, hey, wow, look at that, look at your photos before, and look at that. And usually, you know, patients making this kind of progress, it often continues to move forward. And so they just kind of have to stick with it. But, you know, it does, again, remind them at the beginning that it takes a long time. And then I think you'll have, you know, better adherence over time. But you can see this patient had had disease for 11 years. That's a very long time. And look, you know, 78% improvement by the end of a year. And he, for sure, you know, one can imagine, is feeling, you know, quite different about himself. This is looking at FAAD 50 at week 24. So you can see, you know, this is a patient who is, you know, also showing some improvement at week 12. It's interesting here. Sometimes you'll see this sort of like overshoot of pigment when people are repigmenting. So you can get like this little bit of hyperpigmentation almost at, in the patches, but that usually, as you can see in this patient, kind of tends to normalize over time. But that's something that we do see clinically, and you know, you can reassure patients about. All right, this is looking at the 50% improvement, you know, very similar curves, obviously a little bit, you know, lower benchmark, so we get more patients getting there, but 75% of patients are having 50% improvement by the end of a year, okay? And then here's what that might look like. This is a patient, you know, again, you can see having a little bit happening at week 24, that nice, you know, perifollicular repigmentation, but she's also getting, you know, looks like maybe a little marginal too, looking up, you know, at her forehead there, that pigment creeping in. And so you can see by week 52, she has about a 60% improvement from her baseline. And, you know, again, showing how that this can take time, and it's really different for everybody. Here's another example of a patient. This patient hit an FAAD 90 at week 24. You know, he just repigmented very quickly. At 12 weeks, you can already see, you know, really significant improvement. I do think another thing to kind of point out to patients is that sometimes that in between repigmentation can be tricky, I think, for people, because it, you know, it's not always totally uniform, and sometimes that makes it a little more obvious, like for this patient. So sometimes, you know, they may sort of, you know, cosmetically prefer, obviously they're going to prefer the complete repigmentation, but sometimes they have to kind of work through that in between time. Most patients are excited that they're getting pigment back, but I think just something to keep in mind, that just because they're getting their pigment back doesn't mean they're going to be, you know, over the moon, because they still don't completely look like themselves, right? But you can see by week 24, really pretty incredible improvement there. And this is looking at the patients who got to an FAAD 90. You can see about 30% of patients hit that really strict, stringent benchmark by 52 weeks. All right, and here's an adolescent. This is a nice example of the sort of that overshoot of the pigment, where you can see that little bit darker pigmentation there. But again, as I mentioned, that tends to kind of even out over time. And you can see she had almost complete repigmentation by 52 weeks. And you know, what a dramatic difference looking at her eyelids and that periorificial. This, you know, you can just think about being an adolescent, and I think without vitiligo or without any inflammatory skin disease, adolescence is tough. You add this to it, this very visible difference, and you know, one can imagine, you know, what life might have been like for her. So pretty dramatic responses. Okay, so now we're going to look at the body. So you can see, you know, face, again, remember, face, high density of hair follicles tends to repigment really nicely, or fast. Here's an example of a patient looking at, you know, their T-VASI score. So this is their total VASI outside the face, and this is a patient who had about 50% improvement by week 24. This, you know, face tends to do better, but you can see when you're looking at 50% improvement, about half of patients get there. So that's sort of a nice thing to say, you know, in looking at the body outside the face. If you look out to 52 weeks, about half of patients get about 50% better. And again, look at the slope of this curve, right? So it's not like you stop improve. Usually, I would say clinically, in my experience, if people are improving, as long as they're continuing to make forward progress, you know, you keep going. It's just the length of time is different in different people. Again, dorsal hand, difficult place to repigment. Fingertips, we're not expecting them to repigment. And just some more examples of, what repigmentation looks like. You can see it on the abdomen there, doing a little bit better. All right, so that was efficacy. I think the photos are really useful in just kind of reminding us that sort of as heterogeneous as this disease is, repigmentation is also completely heterogeneous and unpredictable. And I think, again, I've said it already, but kind of reminding your patients about this, I think you're going to have better adherence and ultimately better success if you let them know at the outset what to expect. All right, so this is looking at adverse events. You can see the numbers here. So application site acne, a little bit more common in patients using Opzelura. In my clinical practice, we see acne with JAK inhibitors not infrequently. I like to say that it's sort of a convenient side effect for us in dermatology because hopefully we know how to treat acne. My recommendation is usually just pretend they don't have whatever disease you're treating with the JAK inhibitor and treat the acne like you would anyways. A little bit of itching, not dramatically different. You can see these are, fairly low numbers, some a little bit more common in the Opzelura group compared to placebo. All right. Let's see. Okay, and this is looking out at 52 weeks again. So we don't have a placebo control, beyond the 24 weeks. You always have to remember that when you look at these. But we do have that vehicle group who switched to Opzelura at 24 weeks, right? So, this was done during the COVID-19 pandemic. So, not surprisingly, there were a number of patients who developed that. You can see acne again, nasopharyngitis. About 17% of patients had some AE, but these are all things, mostly that we're pretty used to, and the most common ones were itching and acne, okay? And basically through week 52, nothing changed. There weren't any additional safety signals. All right, so how about long-term extension beyond what we've looked at? And again, this is a chronic disease for which many patients are going to require chronic therapy. And I think a question, when Opzelura came out is like, what do you do when somebody completely repigments? Do you stop? Do you keep going? That is really tricky because I think most patients are like, I'm there, I want to be done, right? But what does it actually mean to just stop? And we talked about those three pillars of treatment, right? Getting rid of the inflammation, getting repigmentation, and then maintaining the pigment. And, that's something, remembering those memory T cells may be there. You may get a surge of inflammation if you stop treatment. So what actually happens if you do that? So this is basically, so after 52 weeks, patients who met the FAAD 90 could either be randomized to continue Opzelura twice daily or stop. So they got switched to vehicle, basically a withdrawal. And if they hadn't met that FAAD 90, they continued on Opzelura, okay? And they were looked out to week 104. So this is a very, this is nice long-term data that we have. And so the endpoints, we're looking at the time to relapse. So patients who, had met that FAAD 90, how long did it take them to get to an FAAD 75? And then the patients who, stayed on it, what did maintenance look like? Okay, and so, just looking at the two groups, there were pretty similar baseline demographics and characteristics between the two cohorts. We don't have to spend a lot of time on that, but they were, well matched. Okay, so we're going to look at what happened to these patients. Okay, so this is looking at the patients who, again, they reached the FAAD 90 at 52 weeks. They could either continue on Opzelura or they could stop. And this is looking at the percent of patients who maintain that FAAD 90 response. So you can see staying on drug, you get a lot better maintenance of response than patients who stop, okay? This is the number of patients who lost the response. So if you went down under, FAAD 90, some of the patients who had met that did, about a little less than a quarter did lose that. But again, if you stop, you're getting over half of patients who are losing their response. And then there were some patients who dropped out or didn't follow the protocol. So we are not sure what happened to them. But basically, many of these patients are going to do better if they keep using treatment, okay? And I think, again, understanding the pathophysiology, that these memory T cells can be hanging out there or can come, can get a resurgence of inflammation, that kind of makes sense, right? And so, the patients who relapsed, went, less than the FAAD 75 and got retreated, about 75% of them regained that response within a median of 12 weeks. So say that's pretty quick, actually, considering how we're talking about how long this takes. And this is looking at cohort B, and this is looking at the patients who hadn't met the the FAAD 90, who stayed on Opzelura, how many of them were getting that over time. And so again, we saw the slope of those curves. Probably not too surprising that this number, the number of patients who are hitting that benchmark continues to increase over time. So the longer you stay on it, probably the better you're going to do if you haven't met that endpoint, by the time you're at. Okay, so again, talking to patients about this is like, we're talking years now, right? This is not a cream that you're going to use for 2 weeks and get the response you want and then be done, right? This is a chronic disease that's going to require a chronic therapy, and most patients, if they discontinue, they're going to lose their response. Okay, and so again, I think the sort of question of what happens when we stop, some people will maintain, but a lot of people won't. And then remembering how long it takes to get the pigment back, I think is really important, because again, we're not talking about psoriasis or AD, right? You flare, you restart treatment, probably in a few weeks you're better. That's really different here with vitiligo. So the stakes are, really high. So this is a nice example of a patient who met an FAAD 50 at week 52, but you look at him out at week 104 and he's almost completely repigmented. Okay, and so this, again, marathon and not a sprint, takes a long time, but he's, having that positive reinforcement along the way of all that perifollicular repigmentation. And, in real life, I wouldn't be surprised if he kept going, because we're still seeing some of that at week 104. And then this is looking at the body, not just the face, and many of these patients also continue to see improvement. You can see the number of patients getting there increases over time. Okay, and this is just some more photos for you guys. Hopefully, I think you've seen a lot by now, but just sort of the different ways that people can repigment. Again, and this patient wouldn't necessarily expect right up to the, wrist to repigment, but the forearm did really nicely. And again, these patients had disease for a long time. So this is something, just because you've had it forever, or, 8 years, doesn't mean that you can't treat it. And this is different. I treat a lot of alopecia areata, and that's a disease in which there is kind of this window of opportunity. And what's really interesting is that seems to be different in vitiligo. So that's really nice. So that patient who, you're seeing for something else, and you're like, oh, you have vitiligo. Oh yeah, doc, I've had it for 20 years. You could say, well, hey, do you want to try? There's a treatment, like you might actually get there. And some of these patients will say no, but a lot of them, they would like more than anything to kind of be normal again, right? And so I think, it's our job, even if they're not there for vitiligo, to bring it up to them and say, hey, there's this cream. And, if somebody has more widespread disease, maybe they care most about their face, or maybe they care most about their forearms, and you pick an area that's kind of your target, and that makes it easier, to kind of adhere to. And then, down the line, if patients want to do more than that, of course they can, but, we may need to be the person to bring this up. And then that patient, if they do well, obviously they're going to be really grateful to you that you kind of said, hey, you went beyond what they were there for, and said, told them about this, because most patients don't, how would they know, right? They don't know, and let them know. So this is looking at AEs at 104 weeks. You can see these two different cohorts, whether they met the endpoint, initially or not. COVID-19, again, the highest thing that we see, upper respiratory tract infections. You can see there were some things that happened with Opzelura at, higher rates than in vehicle, and then vice versa. And, most of these were not thought to be treatment related, and there were no additional safety signals through week 104, which is always nice to see. So let's kind of talk about that box warning, okay? This is, I think this is what often holds people back, for sure, from using oral JAK inhibitors, but I think it, it may give people pause about using Opzelura. And I think, look, this is a tool that we have for patients, and our job, we all went into medicine to help people, right? And our job is to make them better if we can, but we also want to do that in a safe way. But so that means we have to have all the information that we need in order to have, an informed conversation with them, and help them, make the best decision for them. So you may have heard about the oral surveillance study. So this was a post-marketing safety study that was mandated by the FDA for an oral JAK inhibitor, Xeljanz, which was initially approved for rheumatoid arthritis. And this was a study looking at patients on Xeljanz who were at least 50 years old. They had to have at least one cardiovascular risk factor. Many of them, basically, they were all taking methotrexate, and they compared that group of patients to sort of the same characteristics of patients who were on TNF inhibitors plus methotrexate. And so the patients who were taking Xeljanz had, at the end of this study, had a higher rate of death, malignancies, major adverse cardiovascular events, and clots, okay? And so these are words that we all need to know. We need to be able to talk about this. We have to understand the context. And so basically, because of this, the FDA, most JAK inhibitors approved for inflammatory skin disease have this box warning on them, okay, because of a similar mechanism. And so that box warning is on Opzelura, and I think it's something that's important for us to talk about. You for sure don't want to gloss over it and have the pharmacist say something to the patient and then they don't trust you, right? Afterwards, it's, if you don't say anything after and they come back to you, it's like an excuse, but beforehand it's an explanation, right? And I think we owe it to our patients to give them, all of the information. So I do talk about this with patients. Again, we sort of went through all of these things, but increased risk for infection, malignancy, mortality, VTE, and MACE. So let's look at some of these things, sort of the things that keep us up at night. And you can see, these numbers are not zero, but they are, quite low. You can see there were no MACE events. This is looking at per incidence rates per patient year of per 100 patient years of exposure. Okay, so I should have said that initially. So when you have, when you look at the first part of a clinical trial and we look at AEs in the placebo-controlled period, we look at all percentages. Okay, and those are things we're going to see commonly, right? The upper respiratory tract infections, the things that are going to show up kind of early. When we're looking for more uncommon things, we are going to need more data to see that, right? And so we lose the placebo control a lot of times, and because we're looking at open label extension data, right? And what we look at is not percentages, but rates per 100 patient years of exposure, okay? And so you're going to see that in most of these tables for this sort of adverse events of special interest. And so when you look at these numbers, a 0.5 means 0.5 per 100 patient years of exposure. So if you treat 100 patients for 1 year, you're going to have half of an event. So you could also think about it like if you treat 1,000 patients for 1 year, you might see 5 infections, okay? And so you can look at these numbers down the line. Again, the numbers are not zero. Sometimes they are. MACE, you can see 0 with Opzelura, 0 lymphomas, no deaths. Otherwise, 1 in 1,000 for VTE, TIA, et cetera. Okay, so that's not to dismiss this, but I think it's really useful to have these numbers in the patients that we're treating, right? Because I think, these are not patients on an oral JAK inhibitor with RA over 50, right? These are patients who are, using a topical, and many of our patients with vitiligo are fairly healthy, right? And they may not be on other medicines, but again, I think it's important to talk about the box warning, use all the words, but then say, look, here's the data that we have in patients with Opzelura, and I think all of that is very reassuring. So when you're starting treatment, this is a cream. Really importantly, it's not a steroid. I think, we all know that, but patients don't know that, and everybody's afraid of steroids. So I think it's actually useful to say this is not a steroid. People kind of like to hear that. And what's nice is that it can be used on sensitive areas like around the eyes, around the mouth, because these are places where vitiligo likes to go, right? Eyelids, super common. It was studied on the eyelids, and then the external genitals, but it cannot be used in the eyes or in the mouth or intravaginally, okay? It's for topical use only. It's a twice daily medication. It's hard to do anything twice daily, but your patients are going to have the best result if they do it twice daily. So you just have to have them kind of get in the habit of it. And again, if they feel like it's too much for them, then they pick area, they pick their face, they start with that. And again, up to 10% body surface area, but it can be used continuously for vitiligo. They should not use more than 1 60-gram tube weekly. you're probably never going to get more than a 60-gram tube approved per week. And again, if you're using 10% or less body surface area, that's not going to be an issue. Again, these setting expectations at the beginning, I think, is the most important thing. You probably feel like I've said it a million times, but if you don't do this, if you just say, here, go use this cream twice daily, your patient, like, it's not going to work because they're not going to do it appropriately. They're going to give up. They're going to say that was, you know, that was not worth my time. But if you see them back, if you have photos, if you tell them at the beginning, this is work, you know, you have to stick with it. But if you do, you will, you know, you're likely to have a response. I think that, you know, you're going to get better adherence and success. And again, it's really fun to see these, you know, these really remarkable changes in patients' appearance. Okay. So this is just looking at laboratory, you know, stuff. You do not have to check labs on Opzelura. You know, it's not something that's been studied in pregnancy. It should, you know, if you do have a patient who becomes pregnant, they can, you know, you can put their data into a registry. People should not, you know, breastfeed when they're using Opzelura or in at least 4 weeks after the last dose. Okay, and all of this is in there. So, so coverage, this is a big deal, right? You know, it's one thing to have a medicine that's exciting, but if we can't get it for our patients, that's not really useful, right? So 80% of commercial lives covered now. Really important, you know, to have the right information in your note for the prior auth. They have to be at least 12. They have to have non-segmental vitiligo. Most patients have to have failed a prior therapy, either a topical corticosteroid and or a topical calcineurin inhibitor. Even those are not approved for vitiligo, we know what insurance companies want to see. And then again, you can treat up to 10% body surface area. There is, you know, there are these multiple patient assistance programs that your reps can help you with, where they can get, you know, bridge support, they can have copay assistance, all of this stuff. So talk to your reps and they'll, you know, they'll get you the things, the resources you need to get your patients on drug. So that is it. This was kind of the whirlwind, but I think, you know, the big takeaways is this is the first and only approved topical JAK inhibitor for vitiligo, the first treatment ever for repigmentation. It's approved as young as age 12, which is really great since we do see a lot of adolescent patients with vitiligo. Really important takeaways, you know, certain body surface areas are going to, you know, be more likely to respond than others. You have to set these expectations at the beginning. Repigmentation takes time. Adherence is really important. But again, it's not a steroid. You can use it on eyelids, around the mouth, and then the most common adverse reactions, again, acne and itching at the application site. So that is it. Thank you all for listening.
Again,
And
if you'd like to submit any questions, just use the question chat pane on the right-hand side of your screen. And if you think of any questions afterwards, you can always send them to info@idefeducationalseries.com. Also, we'd like to thank our supporter, Incyte Dermatology, for making this educational event possible. So, Dr. King, do we have time for a couple of questions?
We do, and we have a couple of good ones. So the first question is the pigment overshoot that you described, or the pigment mismatch that can be seen with treatment, especially I think early in repigmentation. The question was, does the patient continue to apply to those areas and they'll eventually normalize, or do you pause therapy on those pigment mismatch areas?
yeah, that's a great question. And again, I'll preface it by saying this is not something that's studied. It's more of sort of a clinical observation, but I would have the patient, you know, continue in all those areas, right? Because remember, the stakes are high here and we don't want those, you know, that inflammation to be creeping back in there. So in the, you know, in the trials, patients continued in all those spots. Do you do the same in clinical practice?
Yeah, I do. I think that's right. I think we keep treating, and the vast majority of the time, there's, you know, the pigment evens out between those areas that kind of overpigmented and the patient's background color or
I like to tell the patients that
pigmentation.
their melanocytes were just so excited that they, couldn't wait to get out there. And so you put that positive spin on it. And I think, again, sometimes, that's not something I always counsel about in the beginning, but if you see it, I think just reassuring the patient that this is something we do see not infrequently and that it's normal, I think is useful.
And then another question is, how do you counsel the patients about the differences between facial repigmentation and then body site repigmentation, and the differences in expectation between those places?
Yeah, I mean, I think that's huge, right? I'm sure you also, Brett, have seen patients coming in who are, putting a topical steroid on their fingertips every day for 6 months, and they're like, why isn't my pigment coming back? And that's like, because it's never going to, right? And so we, it's hard. I think it's really hard to tell patients that, right? It doesn't feel good to tell them that we can't help them in certain areas, but it is our job, and patients really appreciate that. Like, nobody wants to do something that's futile, right? So I think, most patients care most about their face. So I think it's really nice that the place that tends to respond the best is the face. So we can talk about that and say, hey, look, this is actually, I kind of geek out and tell them about the hair follicles and the melanocytes, and, you have a lot more of them here. And so I think, just saying that from the beginning, but also that everybody's different, right? You don't want to say, oh, your face is going to go really fast, and then the patient comes in, their face is taking longer than their knees or something, right? So I think just saying that in general, places, explaining it, places with this higher density of hair follicles are probably going to do better or respond faster, then they're kind of, they're prepared at least.
Yeah, I agree. I think it's critical, because otherwise, again, if they're aiming for something and if their expectations are way high, and we could have just told them, oh, no, look, I need you to understand this part is going to take longer. And so you have the expectation of this on your face, and you have the expectation of this on your chest or on your arms, just to help them know what the journey ahead is like, to prepare them to sort of do everything that they need to do to achieve the best results.
Yeah, and again, this may be something you have to say multiple times, right? Because people, there's a lot that happens in a visit. I mean, I leave the doctor and I'm like, what did they say, right? And so this might be something you want to write down, or you just have to kind of reinforce over time. But again, I think the photos are really crucial, because when patients do see improvement, it's motivating, right? And you, again, I think I said, like, you can kind of be their cheerleader, and I think sometimes you need that. So even though you might not be expecting to see that much, early on, if you have the luxury of having them back sooner, then it may be useful just to check in, kind of reminder, like twice daily is best here. Like, I think that ultimately your patients will benefit from that.
Great, thank you so much, Dr. Craiglow. We really appreciate your insight and your presentation, and thank you so much to the audience for tuning in to this webinar, and I'll turn it over to you, Roxanne.
Thank you, and thank you, Dr. Craiglow, for such a great presentation on this really amazing medication for the vitiligo patients. And thank you all for joining us this evening. Don't forget to join us on this Thursday, for a presentation on a newly approved foam to help simplify treatment for seborrheic dermatitis. So everybody, good night. Thank you.
Good night.